Thanks for the opportunity to talk about MAS. I'll apologize for overlap with our previous distinguished speakers, and this is certainly focused more towards the parents and patients and towards being entertaining. So with that, what is macrophage activation syndrome? I think many of you are more familiar with this certainly firsthand than I am, but it's a syndrome. It's a collection of symptoms that includes fever. I tend to break out the different cytopenias separately because I think the things that cause them are different. Um, low white blood cell count, low red blood cell count, low platelets, abnormal clotting, sometimes resulting in this entity called disseminated intravascular coagulation, or DIC. Um, Hepatitis, or at least transaminitis, this thing called hemophagocytosis we'll talk a bit about, and then this dreaded ferritin. And if left unchecked, as we've discussed, it can be fatal. We don't have great numbers on this, but it's certainly a state of immunopathology that we want to recognize and try to prevent. So what isn't macrophage activation syndrome? Well, I think it's important to make a distinction between a syndrome and a diagnosis. A syndrome is a collection of symptoms that flow together, but generally suggest that we don't really understand what's driving them. And I generally think of MAS more as a description of someone's state of inflammation at a given point in time. And like pretty much everything else in biology, it's not binary. It's not like you flip a light switch and you have MAS or you don't have MAS. And as previous speakers have mentioned, this sort of idea of smoldering MAS, and that there are maybe two patterns that we see in systemic GI stills, where you have patients that have a more systemic component, where they sometimes will smolder and then sometimes tip into what is more clearly MAS, and other patients that have a more chronic and more sort of articular or arthritic predominant, and that these seem to be somewhat mutually exclusive at any given point in time, but that people can jump between the two. So why do we call it macrophage activation syndrome? And I think the naming here becomes important. So this is from a great cartoon put out by Cincinnati Children's of an angry macrophage, which made me think of a Red Hulk macrophage. But nevertheless, we call it that because, in the olden days, when they named diseases, they named them after what they saw under a microscope. And in macrophage activation syndrome, they saw these really activated macrophages. Some of them were just really activated, like this one over here, this one down here. But others had sort of become so activated that they've started engulfing other hematopoietic cells. So here's a hemophagocyte, which is an activated macrophage that has, some red blood cells or some digested lymphocytes inside of it. And so the nomenclature is somewhat important because we talk about MAS in the context of systemic JIA, but it's really a physiologic entity that exists with a whole bunch of other what we might call cytokine storm or hyperinflammatory disorders. And they go by various names like, viral sepsis or hemophagocytic lymphohistiocytosis. You might have heard of cytokine release syndrome in association with certain cancer therapies. And what name you use is often as much a consequence of who's speaking it as it is what's actually driving the disease. So, you're all biased because you're talking to rheumatologists, and we'll call this MAS, but hem-oncologists simply think of MAS as another form of hemophagocytic lymphohistiocytosis, or HLH. So are we all just describing the same thing? And many of you have heard the sort of the old allegory of the blind scientists that are all looking at different parts of an elephant and describing it as different things, even though it's one thing. I don't actually think that's the case, but it's somewhat close, wherein I think we're all describing different versions of similar entities. Whether it's an Asian elephant or an Indian elephant, or, something substantially different like a hippopotamus or a rhinoceros. Some things that humans have made up themselves, like, Snuffleupagus, or sort of big, rare, hairy things like familial HLH, which I've chosen a woolly mammoth. So what causes MAS? And I think that the most important part of this slide is the question marks here. I think that there's a lot more questions than answers, but there's at least two pathways that we are pretty sure are contributing. And one is something called cytotoxic impairment, which I'll talk a little bit about. And then another is sort of near and dear to my heart is what appears to be a great excess of the cytokine IL-18. So how can we test for cytotoxic impairment? I'm sorry that this is so grainy. Most of what we know about cytotoxic impairment and cytokine storm comes from a disease called familial HLH, which many have heard of, where people have genetic defects that completely cripple their ability for their killer cells, like killer T cells or natural killer cells, to kill infected cells. And if you lack something like perforin or some of the other genes that are necessary for this, you get this really massive immune activation, especially the T cells kind of go crazy, and it causes a very interferon gamma dependent process, at least in mice. So we can test for this. We can do genetic tests, and there's a variety of functional tests, which I'm not going to get too far into, because I think they're of limited utility in macrophage activation syndrome. They're good for helping us screen for people that have familial HLH, but that's not really what we're talking about. And we're still working on tests that are more sensitive to tell us whether there are cytotoxic impairments at work in MAS in a way that's clinically useful. How can we fix cytotoxic impairment? Well, the state of the art right now is a bone marrow transplant, which is not something that is appropriate for macrophage activation syndrome. It is appropriate if you have one of these genetic diseases like familial HLH, but in our patient population, it's far less clear that it's appropriate, and it's certainly a much more aggressive therapy. So are there other things we can do to address this mechanism without completely overhauling someone's immune system? So we'll get back to that. So how can we test for too much IL-18? Well, we can measure IL-18. And actually, we've known for quite a while that systemic JIA and Still's disease have really, elevated IL-18 sort of to a degree seen in almost no other disease. So this is systemic JIA patients, controls, other forms of JIA, Kawasaki disease, severe infections, and cancer. And you kind of get a sense that it's not normal in all of these diseases, but it's nowhere near what we see in systemic GIA. So this is quite helpful to us diagnostically. And then in terms of monitoring, I think we're realizing more and more that your IL-18 level tells you not necessarily how someone's disease is doing at a given moment in time, but kind of how primed they are for what we might call a hyperinflammatory response. And so this is way back in 2013, our friends in Japan followed a number of patients in this one over a period of 84 months. And A is for active disease, macrophage activation syndrome, and then like induction of remission. And so you can see I threw in this red line here for where the normal IL-18 level is. This patient never really fully normalized, but came down quite a bit. And then as things were sort of more percolated up, the patient was certainly more prone to having an active disease flare. And furthermore, where we see what we still call macrophage activation syndrome, we almost uniformly see a ton of IL-18. And so this is some work comparing a bunch of hyperinflammatory diseases. This is systemic JAMAS. This is infection-associated HLH and familial HLH. These are patients that have those really profound cytotoxic mutation diseases. And again, these are not normal levels of IL-18, but not nearly what we see in our MAS patients. And just sort of following this up in work that we've done here in Pittsburgh, where we screen every patient with a ferritin over 1,000. This is all of the patients that we have found that have an inflammatory cause for their high ferritin. And the ones that have systemic JIA stills, this is all of their IL-18 values. This is the maximum per patient, are really sort of in a league of their own. So I think that we're from a biomarker standpoint dealing with something somewhat unique to this entity we call macrophage activation syndrome. So most of the IL-18 that we're measuring is actually bound up by this recombinant, or by this protein called IL-18 binding protein. So IL-18 is made in cells like macrophages in sort of an inactive proform. It uses this thing called the inflammasome to sort of get activated and get exported. And as soon as it gets out of the cell, in most people, it's gobbled up by this mass of IL-18 binding protein, so that very little of it can actually signal or do any damage. But in patients with MAS, they have so much IL-18 that it kind of outstrips their binding protein, and they end up having free IL-18. We can measure free IL-18 on a research basis, but it's really hard. And I'll kind of leave it at that. How can we test for too much interferon gamma? So, sorry, this is a little disjointed, but going back, you notice that like in a lot of our, oh, okay, well, we're not going to go back. A lot of these mechanisms seem to converge on this cytokine interferon gamma that we'll talk about. But measuring interferon gamma is a problem. It's not a very good blood biomarker. And so folks have turned to this thing called CXCL9, which used to be called MIG. And MIG stands for minokine, which is a cytokine that comes from monocytes that's induced by interferon gamma. And so it's kind of a very sensitive and highly dynamic biomarker for interferon gamma activity. And so this is from that same cohort showing that, yeah, all of these different hyperinflammatory diseases have really high CXCL9 levels, like we don't see necessarily even in active systemic JA or controls. And this is from actually a clinical trial in patients with largely primary HLH treated with a drug that blocks interferon gamma, sort of showing that the likelihood that you were to have a good response to blocking interferon gamma was related to how high your CXCL9 levels were. And so we can measure CXCL9 as a readout of interferon gamma, and we can measure IL-18. So how do we treat MAS? Well, the mainstay and what all of you have been dealing with, throughout the whole course of your diseases has been clubbing the immune system with glucocorticoids. And this works pretty darn well for, most patients to start out, but it has problems, it has side effects, and it's certainly not enough for everybody. And so in many patients, we quickly graduate, as Dr. Graham mentioned, to things that are more sort of poisons for the immune system. Some are sort of milder or subtle poisons like cyclosporin that are actually pretty well tolerated, and other are more potent poisons like etoposide or cyclophosphamide. And then, of course, many of you are going to have experience with drugs that block some of this cytokine storm, like anakinra, which is a recombinant version of a protein that we make anyway that blocks the IL-1 receptor. Now, there are other IL-1 blockers. We tend not to use them as much in MAS because anakinra works really fast and we can play with the dose much more sort of carefully. So can we do better for MAS? Well, thinking about whether you've gotten to your MAS through a cytotoxic defect or through lots of excess IL-18 or through a combination of the two, you have this cytokine storm, and we now have tools to sort of go after it. So among those tools are things that can try to mop up some of this excess IL-18. And there's a trial ongoing now in genetic forms of MAS using a drug called tadakinib, which is a bit like anakinra, but for IL-18. It's a recombinant version of a protein our bodies are making anyway. It's a recombinant version of this IL-18 binding protein. I just mentioned emapalumab, and I'm going to talk a little bit more about that, which is now FDA approved for refractory HLH, and it kind of mops up and sequesters interferon gamma and prevents interferon gamma from signaling. And then you've heard a lot about these JAK inhibitors, which stand for Janus kinases, and they block signaling through a lot of different kinds of cytokines. They don't block all the cytokines, but they block interferon gamma signaling and IL-12 and IL-6 and a host of others. And they go by names that end in itinib, like tofacitinib and ruxolitinib and baricitinib, and there's a whole host of other JAK inhibitors coming out that we're learning more and more about using them both in systemic J stills and in MAS. So to talk briefly about something that I think probably Dr. Benedetti is going to talk more about later, this is some data that they showed, I guess it's been more than a year now, of this interferon gamma blocker emapalumab in a few patients with MAS who hadn't had full responses to IV steroids. So this isn't everybody with MAS. This is sort of already pre-selected for some folks that were harder to treat. This is their CXCL9 levels as a readout of interferon gamma activity. And when you give them the drug, their CXCL9 levels drop pretty nicely, and so do lots of their other biomarkers. And so this is still very preliminary. None of this has been published yet, and I'm not the expert on it. But I think that we should all stay tuned. And so wrapping up, because I wanted to leave some time for questions, I think the future looks bright. for MAS. I think that we're getting better, learning more things about how to identify susceptibility to MAS, both genetically and from functional standpoints. I think that we're getting better at the bedside at identifying the first signs of MAS and recognizing that you don't want to wait until somebody's in full-blown MAS before you intervene, especially now that we have targeted, potent, and safe treatments to intervene in MAS before it becomes, full-blown. However, I would point out that, the future looks bright, but there's a long way to go. There's a lot of work to be done in clinical trials. There's a lot of work to be done in genetic discovery. There's a lot of work to be done in biomarkers and functional discovery. And I know that, you as parents and we as researchers want that future to be now, but we can't neglect the fact that hard work still needs to be done. So with that, I'm happy to take any questions.
Yes, thank you so much, Scott. That was great. Yes, the future cannot come fast enough because I think a lot of people sitting there will tell you have the signs of MAS, and what do you get first? IV pulse of steroids. I mean, that's the reality still. So, okay, I'll go on to the question. So we have a question from Pauline who's saying, have you seen any HLA genetic variants that can be associated to MAS? If these variants show up, then does that mean that the patient will have more MAS episodes?
I'm looking for the question. These are HLH or HLA?
HLH
Okay.
genetic variants. Yeah.
So it's the genetics of the HLH genes is a little bit tough in MAS. Almost all of the genes that cause HLH, you need to have both copies kind of damaged in some substantial way in order to get HLH. And what folks, not me, but actually quite a few, like Dr. Grum and Dr. Schulert and Dr. Umbrello and I think even Dr. Mellons have shown is that you find more patients that have one damaged copy of an HLH gene in MAS. How much more is a matter of some debate. But if you look in regular healthy populations, you find a lot of those one copy hits as well in people who will never get systemic JIA or MAS. So it's probably one piece of the puzzle. It's something that we're actively studying in my lab in kind of a model system way, because we can model those things in cell lines and other systems to see how these subtle effects might interact with things like IL-18 or other triggers to add up to the totality.
Oh, it looks really good.
So good. Perfect.
Oh yeah.
Somebody needs to mute. Yeah. Okay. So how can you recognize subclinical MAS?
Well, I think that we're recognizing it all the time, right? When our patients come in and their ferritins are 600, but their platelets are still normal, I think that we call them sort of MASE or smoldering MAS or something like that. And so I think that some of the treatments that we use, you'll see the same drugs keep coming up, whether we're talking about systemic GIA or we're talking about MAS. It's steroids, it's things like anakinra, and then the future of things like JAK inhibitors and maybe emapalumab and maybe IL-18 inhibitors. So, I think that that's actually not the problem. It's really more what's the right level of intervention.
Okay. If you have a refractory child, should you be pushing for getting the IL-18 checked?
I think we're still learning how to use it. I think that probably every patient who gets a diagnosis of systemic JIA should probably have it checked, at onset, because not every systemic JIA patient has really high IL-18 levels. And it's been my sort of anecdotal experience, and there's some evidence to support this, that the folks who don't have such high IL-18 levels still have systemic JIA, but they're going to sort of move in a slightly different direction and might respond better to different drugs. In terms of following, I think that there's studies ongoing trying to tell us whether normalization of the IL-18 should be something that we use to help us decide when someone should come off therapy. Or likewise, someone who seems to be doing well, but their IL-18 levels are still really high, may not be doing sort of as well beneath the surface as we think they are.
Got it. Now, what do you think about like just minor elevations in IL-18? So for some kids like my child, when IL-18 is high, it goes up to like say 100,000. But then there are, families in which the IL-18 might go up, like the normal is maybe 400 and it'll be like 600. Is that concerning or is that not concerning?
It is not, is my opinion. I think that, if you just Google, IL-18 and any disease of interest, you'll find that it's high. Probably anyone who's gotten the flu, their IL-18 will go up to maybe 600, 1,000, and then it will come back down. And so, it's hard for me to point to a cutoff. Different studies have pointed to different things, and people measure it slightly differently. But, somewhere in the range of, 10,000 up to maybe 40,000 is kind of the cutoff where we really start to sit back and say, yeah, that's consistent with systemic GIA MAS. But like I said, there's some more work to be done there. In my group, we try to integrate in measuring binding protein at the same time. There's this free IL-18 assay, which I think has some utility, but is not as sensitive as we want it to be. So, the total IL-18 is available at Cincinnati. A few other sites run it internally. And I think that we're learning more and more what to do with it.
Okay. One question. If a patient is on Ilaris, can anakinra be given on MAS? And if I may ask, if Randy Crone is on the line, maybe he can also chime in there.
Can it? Yes. Have we done it before? Sure. Is it easy to get approved? Not particularly. But we've certainly had patients who have been doing pretty well on Ilaris, who for bumps in the road, we will do anakinra, to get them over those humps. I have a patient who reliably flares every time she gets a flu shot. And so she's on Ilaris and we give her some anakinra around her flu shot. From a safety standpoint, I think that is fine. Logistically, it can be challenging.
Yeah. So actually that's an interesting point you're making, because in the autoinflammatory, some of the genetic autoinflammatory diseases, we definitely see that kind of a management where they are on Ilaris on a kind of, that's their regular drug, and then using anakinra for flares. And actually they seem to manage to get that approved by insurance. It might take some work. Is that possible for SJIA to have that kind of a strategy, that if you see a little bit of like, some kind signs of MAS, then you add in the anakinra?
Yeah, I mean, I think it makes just as much sense in systemic GIA as it does in a genetic autoinflammatory disease. I think that the greatest obstacle there is just getting both drugs sort of in the hands of the patient at the same time.
Yeah. Yeah, well, we all live and die by peer-to-peer, getting all of you spending your time on insurance.
And as much as I think we all are very hard on steroids, there's a reason we still use them. And when I teach our residents and fellows, I say, just imagine the sort of hellscape we would live in if there were no steroids. We use them for every disease, and they work spectacularly in many situations. So, I think that sometimes, for those little bumps in the road, if you're confident that it's just going to be, a short course of steroids, I'm not sure that that's any more dangerous than a daily shot of anakinra. The problem is that, weeks become months, become years.
Yeah, exactly. I mean, I'm going to push back on that. And I'm going to say that, chronic steroids, even if you are doing pulses, are a real problem. There's all sorts, so many of the parents here will tell you about, all sorts of problems, bone issues, height issues, eye, optimal eye issues. I mean, like it's a very destructive drug. And the usage, casual usage in a refractory patient after 5 years of disease is very different. So
completely agree. Completely agree. Yes. I mean, it is the double-edged sword in rheumatology. And yeah. And especially to this audience, I don't need to tell you that steroids are both your saving grace
Yeah,
and
you can
the
see,
worst thing you deal with.
if you see the chat, you'll see.
Yeah, I know. I'm
Okay.
used to getting yelled at. That's fine.
So Michael Umbrella is saying, I may advocate moving beyond the IL-1 directed treatment if MAS develops on canakinumab treatment. Well, maybe we'll have a chance to hear more about that on
Yeah,
Friday.
maybe that's our segue.
Yeah, segue.